Hi, good evening, everyone, and welcome to the COVID-19 Community Town Hall for the Upper Peninsula. Our Town Hall series is presented by UP Health System Portage. I'm Steve Elmer. I'll be joined shortly by my co-host and colleague, Dr. Kelly Kam, who's our epidemiologist here at Michigan Tech University. We're both members of the Health Research Institute and college professors here. We want to give a warm welcome to all of our viewers joining us tonight on Zoom, on social media through Facebook Live, and all the listeners out there tuning in on 97.7 The Wolf. We appreciate you being here, and we are ready for another town hall. Just need to recognize our sponsors for tonight, which include the MTech Smart Zone, Upper Peninsula Power Company, Aspirus, the Physiological Society, and once again, our presenting series sponsor, UP Health System Portage. We really appreciate the support of our local sponsors and professional organizations, also in addition to our campus partners, which includes the Health Research Institute and the Center for Educational Outreach. It's important to note that the town halls are organized by the Health Research Institute, and their mission is to support health-focused research and inspire education and outreach here on our campus and in the broader community. The goal of our town hall tonight and every week has been to increase our awareness about COVID-19 and how it impacts your health, the health of our community, and society at large. Just want to remind folks, if you missed any of our previous town halls, these are publicly available, they're free. You can go to our website and download these. Each week we've covered a broad range of COVID-19 related topics. Tonight's topic will focus on health disparities in COVID-19. I think we have a really exciting lineup of speakers and information that we'll present. Remember that we rely on experts to present credible information. There's no sides here. We're presenting the public health information to help protect our community. Our website again is mtu.edu/health-research. Once you're on the page, go ahead and click on Town Hall. You'll be able to find all of our recordings. Next, I want to welcome and bring in my colleague and co-host, Dr. Kelly Kam, who's our epidemiologist again on our campus. So Kelly, welcome back. We're here for our 12th and final Town Hall of 2020. So how are you tonight?
I'm doing good. Thank you for having me, Steve. And I'm excited too to hear what we have for our last session here.
Yep. Well, likewise. Well, can you tell us what's coming up tonight? I know you're going to give a brief public health update, and who are our speakers tonight?
So we have two speakers to talk about some different perspectives of what's been happening with the pandemic from a couple of different areas. So we have Dr. Heather Oram, who's an associate professor from the Department of Community Health and Health Behavior at the University of Buffalo, my alma mater. I'm excited to have her here to talk to you today about racial disparities in COVID-19. And we have Whitney Elmer, who's a country director of Mercy Corps, which is a humanitarian aid organization that works globally to help improve the situation in a lot of underserved countries and low-income countries around the world. So she's going to be here to be able to give you guys give all of us a global perspective on the pandemic.
Well, Kelly, I think we'll really hit, I know you're giving an update too, a little bit more local, regional, so I think we'll hit all of the levels today across the spectrum. You know, each week we add to our helpful resources here. Kelly, can you just hit some of the high points for our viewers and also our listeners out there on the radio, some websites where they can go and find that credible information, all things related to COVID?
Absolutely. So we have to remember that some of our best resources are our local and state and federal public health departments. So CDC, your state health department, wherever you may be located. In Michigan, it's the Department of Health and Human Services. And our local health departments. So for example, our Western UP Health Department covers a 5-county jurisdiction, or wherever you're living with the health district that you live in. A lot of our resources are also available on through our health systems. So we have 3 major health systems in our area: UP Health System Portage, Aspirus, and Upper Great Lakes Family Health Centers. Those have some great information, as well as information if you're actually needing medical care related to the pandemic. And then we also have some other resources that can provide a lot of different aspects on it, such as the World Health Organization can give a global perspective on it. And Copper Country Strong can provide some information on resources that might be helpful to you living here in the Copper Country area.
Okay. Thanks, Kelly. I wanted to expand upon that here just a minute, and also talk about some programs that some of these we've featured on the town hall and others that are just coming about. One is the Tech Tutors program. That's a free virtual tutoring program provided by Michigan Tech students for students in our local K-12 schools. So if there are any parents or teachers out there that need some help with tutoring, our Michigan Tech students are here to help. That website is techtutors-mtu.org. That was techtutors-mtu.org. There's a new course for any students on campus that are tuning in tonight. I know there's several. There's a military conditioning course. This is put on by our Army, ROTC. A couple of things I want to mention about the course. It aims to develop physical fitness, confidence, resilience, and camaraderie, working around the COVID-19 constraints and social distancing. If you'd like to get more information, you can contact the Army ROTC and contact Major Gouache. Last thing I want to highlight is the Community Physical Activity Program. We've featured this a couple times. This is called Up and Moving. This is a great way to stay active during the pandemic. They offer physical activity workouts that are guided by our Michigan Tech students. You can go to the website at upandmoving.org to find out more information. So Kelly, I'm going to turn it back over to you, and I know you're going to give us an update. It's been a couple of weeks with Thanksgiving off, but a lot has changed, and so what's going on here on a local and a regional level in our state?
Yeah, so starting off, which I don't have a graph of here today, but starting off with what we're looking at globally, we're over 65 million cases globally and 1.5 million deaths. And that's what we're heading towards right now. And in the United States, we certainly are on the upswing here. So almost 14 million cases, almost 200,000 cases in a single day, looking from yesterday. So we are definitely seeing, and as you can see in that graph below, that the slope of the curve, it's getting a lot steeper all of a sudden here in the last several weeks. And that's really been the thing that's been concerning, that as we have this exponential growth, it's just going to keep going until we actually are able to change our behaviors to do something about that. So in the United States, we're looking at over 270,000 deaths, just about 2,800 deaths yesterday. And again, remember that those, as I talked about before the Thanksgiving break, that the deaths are lagging about 2 to 3 weeks from the cases. And so as we're seeing these cases skyrocket, we do expect to see these deaths increase. And although we can do something about infections that have not yet happened, many of these deaths, as we're forecasting, they are going to happen, unfortunately, because these people are already infected. Next slide, please. So looking at what's going on in Michigan, as we are, many of you know that are living here, we are under epidemic orders right now, and continue to be so until December 8th or 9th on that. We are seeing cases that are high. It's a little early to see yet if anything is leveling off or even decreasing would be really good. But we are still quite high. Yesterday, daily confirmed cases of over 7,000 cases in Michigan alone. And as we can see, our areas here in the Upper Peninsula, these are rates, so they are per million people. So we can see along the southern UP there, we have quite a few cases and very high rates. So that's what we're quite concerned about. I also wanted to show the difference on the right here of looking at where our ages of people who are infected as well as the ages of death. So as you can see that for our younger listeners, they are a good chunk of our cases. So there's over 50,000 cases that are in our 20 to 29-year-old age group. And so it's not that you can't get infected, but the deaths are occurring in the older age group. And so we do have to remember that the actions of all of us here are going to affect the actions or the health of others in our community, and particularly those in our older age groups that are at really high risk of severity of death and severe outcomes. Next slide. So there's been quite a bit in the news lately looking at whether our hospitals are going to be reaching their peak occupancy and what that might mean to the health, not only for people who need to be hospitalized for COVID, but people who need to be hospitalized for other things that are always going to occur. So those heart attacks, those strokes, injuries that are going to occur. And if our health systems are overwhelmed by COVID cases, there's going to be increased death and disability due to these other things not being able to be treated. So just looking at some data, this kind of information is available on the Michigan State website. So for those of you that want to really look at this, it actually lists by hospital what percentage of their hospital beds are occupied right now. So on the left there, I just tried to mark on a Google map some of the hospitals right now that, as of reporting yesterday, were at 90% or greater inpatient bed occupancy. So that includes COVID cases as well as all other reasons for being in the hospital. But about 15% of our reporting hospitals in Michigan right now are at 90% or above, according to the data that was reported on the MDHHS website. Right now, none of these are in the Upper Peninsula, but they are spread across the Central and Lower Peninsula. When we look at it on the right by regions, looking at across the region where our inpatient bed occupancy is and ICU occupancy is, they are all quite high except region 8. We're only at 54% for our hospital bed occupancy, but 81% for our ICU occupancy. And those are adults, so children are not involved, included in those rates. Next one. So there's been a couple of changes that have been in the news, and I just wanted to bring these out for everybody. So in Michigan, one of the new things that we have in terms of notification is the state has this new Michigan COVID or My COVID Alert. And this is a free app on your smartphone that you can get. It is an anonymous app, and so just so that everybody's aware, that's not collecting names or information. It does not share names. It is all protected information. But what the COVID Alert web app does is that it can help with contact tracing because it uses Bluetooth information and data to be able to tell who's been in close contact with whose phone has been in close contact with your phone. And if someone has tested positive, then it uses that anonymous data to be able to send an alert to your phone that says you've had a possible close contact to someone with COVID. So in many cases where we might not know if we've been in close contact with someone, or it's hard to report because you can't remember someone's name, this is a way for you to get notified that you may have been in close contact with someone. As well as on the flip side, if you are a case, you can send out an anonymous alert to others that you are a case and they have been in close contact with you. It also provides quite a bit of information to protect yourself and others. It's available on MDHHS website, so the Michigan Department of Health and Human Services, with all the other COVID information that you can download from whatever app store you use. Brand new in the news as of yesterday is new guidance for the length of quarantine. So this, you may have seen this on some of our news agencies, that CDC has come out with new guidance for the length of quarantine. I want to be really clear that the incubation period of 14 days has not changed. That is set, that is the science behind it. But the recommendations for guidance for quarantines have changed because from a public health perspective, we want to think about not only what the science is, but also the feasibility of people complying with that. And so there is a greater belief that we will get people to comply with a 10-day quarantine. And if we can get 90% of people or even 100% of people to comply with a shorter quarantine, then we will miss some cases that will happen in day 11 to 14, but that's better than only having 50% of the people comply with a 14-day quarantine. So again, you're still at risk in days 11 through 14, but it's a lower risk at that point. The guidance from CDC is dependent that the states are allowed to make their own recommendations if they are going to use that guidance or not. Michigan Department of Health and Human Services guidelines this morning came out that they will use the guidance for 10 days after exposure with no symptoms. So the quarantine will change to 10 days. Our local health jurisdiction, the Western UP Health Department, is reviewing this and will come out with their guidance soon. And so right now, things are in flux right now. If you're under quarantine, hang on, we'll get some information soon on that. And the final thing is we have some good news on the horizon with vaccines. I just want everybody to know that plans are in place for the state of Michigan for distribution in all regions simultaneously. So many of us who feel in the UP, we get things a little later than everybody downstate. It is set that all of this will be distributed in all regions. And the prioritization is determined by federal regulation and recommendations. And the priority 1 group is the healthcare workers, residents of long-term care facilities, and the healthcare workers do include workers at those long-term healthcare facilities. And so it is looking like in the next couple of months, we'll be able to get those priority 1 people start to get that vaccination on board. Next slide. So although we have some good news and we have some changes, I do want to remind everybody that we are looking at some pretty heavy forecasts. And so to remind people to keep up with our 3 W's for watching your distance, washing your hands, wearing your face mask, protecting your own health by adding that 4th W of going for walks, so that these forecasts, maybe we can do something about reducing these forecasts so we don't see, especially when we're looking at those 3 and 4 weeks ahead, that we're changing that slope of that curve at this point.
Kelly, I'm going to come in with a question here. I know we have a couple of questions coming in. Just to remind folks, there's couple different ways to send us questions. You can email those to townhall2020@mtu.edu, or if you're on the Zoom webinar, you can use the Q&A button at the bottom. Couple of questions here, and these look like they're from students. Of course, students that are here for another couple of weeks, they have to travel back home. What precautions, what reminders, what things do you want to emphasize for those that will be traveling over Christmas?
So anybody that's traveling, starting 2 weeks before you expect to be able to travel, start to quarantine yourself. Reduce any non-essential visits that you can. So you want to make sure that you're not going to have any exposures or minimize any exposures that you might have in that 2 weeks prior to traveling. When you're traveling, same recommendations as before. Really be careful. Make sure you're wearing your mask, keeping your distance, washing your hands. If at all possible, to travel in ways that you're not going to be exposing yourself to a lot of other people. So if you can drive, then that's better than being in a crowded airport. If you do need to travel in an airport, remember that your health is dependent on other people's health. So do your part. If you are sick, if you are under quarantine, don't travel. Delay your travel when at all possible, or find another way to travel so you're not exposing other people on that plane. And really, get tested. Again, the testing does not mean that you're not infected, but it's another step in the another piece of the puzzle that can help make sure that you're doing this safer.
Kelly, next question here for you. It sounds like this person received an automated call from the health department. They're a little confused if that's a legit call or maybe a spam call. Can you provide some clarification on these? I've been hearing more of this automated calls from health department.
Sure. So right now, our local health department has had to prioritize based on the state recommendations for prioritization. We are a rural health department, and we don't have the resources that some of the bigger health departments do, and we cover a 5-county area with a lot of cases going on right now. So cases that are considered low risk by age, so between ages 23 and 64, are receiving as a positive or a probable case, they are receiving an automated phone call from the Michigan Health Alert Network. It is a legitimate call. They do not provide any kind of protected health information. The call comes and says, hello, you have been identified as a COVID case. It does not list your name or anything about you individually. So if there is a problem where it goes to the wrong phone number, then there's no personal information that's provided there. It gives you information on that you will need to isolate. It gives you directions on how to isolate and how to notify any close contacts and what close contacts are. And it gives you the opportunity, if you do want to talk to someone at the health department, that you can leave a message and someone from the health department will call you back. I want to be clear that this is, if you have any questions, you ever want to talk to someone at the health department, they will answer your call. You will probably need to leave a message. You won't get a live person, but they will always take your calls, even if you're getting these automated calls. But it allows our health department to be able to handle the cases quickly for those priority groups over 65 who are at high risk of severe outcomes, as well as under 23, which are expected to be in congregate living, congregate schools, where we really want to get those cases. And it's working. They're able to reach those high risk groups very quickly now.
Thank you, Kelly, for the updates. We'll come back with more questions if we have time. I just want to welcome any listeners that might be just tuning in on 97.7 The Wolf. We're here for the COVID-19 Community Town Hall. It's presented by UP Health System Portage. And our topic tonight is health disparities in COVID-19. We're going to move on to our next speaker. It's my pleasure to welcome in Dr. Heather Oram from the University of Buffalo. She is the Associate Dean of Equity, Diversity, and Inclusion, and also an Associate Professor in the Department of Community Health and Health Behavior. So, Dr. Oram, thanks for being here. We're looking forward to your update and national perspective on health disparities in COVID-19.
Oh, thanks so much, Steve. It's really a pleasure to be here. I suspect that this is not a new topic in the room. Most people are probably aware that there are these stark racial ethnic disparities in the impact of COVID-19. But if you'll advance to the next slide, you'll see some updated numbers. So we can see that people of color, so African Americans, American Indian, and Alaska Native and Latinx people have, at this point, 2.5 to 2.8 times, they're more 2.5 to 2.8 times more likely to die of COVID-19, and roughly 4 times more likely to be hospitalized, and then disproportionately represented among those getting the disease. We know that there have been geographic patterns in spread, with the disease hitting urban centers first, and then the South and the West, and then now the Midwest. However, these patterns in geographic spread really can't explain the stark differences in rates of hospitalization and death, and they only explain some of the disparity in cases early on. So, for example, we can examine Michigan county by county and still see stark disproportionality within each county, even those that are by far majority white. So, for example, if we look at the first wave of the epidemic, say making a cut point at April 1st, counties such as Kalamazoo is 35% of the confirmed cases were African American, whereas African Americans only made up 12% of the population. Washtenaw, home of the University of Michigan, it was similar. African Americans make up 12% of the population of that county, and then 37% of cases and 48% of hospitalizations. We even find racial ethnic disparities in effects of COVID-19 on children. So compared to white and Asian children, Latinx and Black children have been more likely to get COVID-19. So in one study, we found that African American children were 2.3 times more likely than white children to get COVID-19. Well, a lot of children have mild or even no symptoms from COVID-19. If children of color were more likely to be hospitalized and more likely to get this very serious COVID-19 associated multi-system inflammatory syndrome. And this is according to a study conducted in New York City. Now let's go on to think about what are some of the underlying causes of these disparities. And they've been covered pretty well in the media. So I'll just boil them down to 3 main factors. And they vary in importance and in detail across different racial ethnic groups. But I think in general, they apply across all people of color. So the first set of factors is the living and working conditions that have made people of color sicker over time, with chronic conditions that are risk factors for COVID-19 disease, such as hypertension and diabetes, heart disease, asthma, COPD. I think we know the list. And I hope maybe in our discussion we'll have some additional time to talk about what are the causes of these living and working conditions. So to really understand them, we have to understand the history of segregation in the United States. I think everybody has a pretty good handle on, and are aware of that, Jim Crow laws that kept Black and white people segregated and Black communities impoverished in the South. However, we have only just started to have this national discussion about racial segregation in northern cities, that the government at all levels, federal, local, state level governments were involved in a very purposeful effort to segregate people of color in northern cities and divest these neighborhoods. And really what ended up happening was the creation of ghettos, high poverty areas. And we see that even today, systemic racism is enforcing these lines of segregation and these patterns of poverty in these communities. And of course, we have a mountain of evidence that suggests that social determinants, these conditions that are made by racial segregation and the disinvestment in neighborhoods, these have created the racial, residential, and workplace segregation conditions that account for much of the Black-white disparity in chronic disease, which then leads to the disparities in COVID-19. We have many studies now that show that this that racial segregation is a foundational cause of the, those diseases that kill most people in the United States. Now, a second set of causes is related. It's the living and working conditions that make people more likely to be infected by COVID-19 or by coronavirus. So people of color are disproportionately more likely to be working in jobs where you can't work from home, where you can't social distance, service jobs, food processing plants, healthcare frontline jobs, et cetera. And in addition to this, more likely to be living in multi-generational families, crowded homes, and also more likely to be using public transportation. So, these living and working conditions, which we can trace back to racial segregation and disinvestment in neighborhoods, lead to the conditions, economic conditions, which force people into these kinds of jobs that would make them more vulnerable to coronavirus. And the third factor that I want to talk about, and here we can move to the next slide, is not having access to high quality medical care. And this, of course, includes testing, COVID-19 testing, because facilities aren't in your neighborhood. Or it also includes not having the same kind of access to high quality treatment. There was really interesting reporting done by the New York Times that showed that at the height of the pandemic in New York City, say April, if you were treated in a community hospital, you were as much as 3 times more likely to die of COVID-19 than if you were treated in a private hospital. And some of what determined what hospital you went to is where you lived. And so we're talking about community hospitals in high poverty neighborhoods, but also some of what determines what hospital you might go to is what kind of insurance you have. Now, what we found was that in these community hospitals with the high rates of death, what was happening was they just simply were inundated by patients and understaffed. So patients would die because they didn't have enough nurse supervision. There's this, examples of folks who would die on their way to the bathroom because they didn't have nursing supervision. They also died because they didn't have access to the same kind of advanced equipment or drugs that would have been available in private hospitals. Now, in addition, people of color we've been documenting for decades now that people of color face bias and discrimination in the medical system. And so this, of course, emerged with COVID-19, that we found that people of color were not getting tested at the same rate, not getting treated with the same quality of care. There are, and I pulled from a story that I had found, came across my desk during the height of the pandemic in the spring. It was a report from Detroit, where it talked about this family, the Fowler family, where Gary Fowler had gone to 3 ERs, been unable to get a COVID test, and had returned home and died in his home. There are many stories like this of people of color who simply didn't get the testing that white people were getting. They didn't get the same level of care. Now in Buffalo, where I'm from, and again, this is really positive news, in Michigan, we have seen pretty dramatic improvement over time in these disparities. So this is really great news. And these communities, both Buffalo and Michigan, seem to be exemplary. We haven't seen these same kinds of improvements all over the country, but what seems to have happened is that in both places, there's been targeted effort to address these disparities. So for example, in Michigan is 15% of the Michigan population is African-American. Early in the epidemic, nearly 30% of cases were African-American people and 41% of deaths were African-American folks. But by September, deaths had become proportional for the most part to the population. In Buffalo, and if we have time, I can talk a little bit about some of the strategies used in Buffalo to address the gap. We have seen a similar closing of the gap. So, if we're running out of time, we can move to questions. Otherwise, okay. So yeah, just to sum up, we can skip this slide because I was going to draw some parallels between what's happening in the rural environments and some of the same causes disparities are creating disparities in rural environments, but we can come back to that in our conversation perhaps.
Dr. Rom, why don't I ask a quick question here and then give you an opportunity. I think our audience would be really interested in that urban versus rural information that you have here. You mentioned the strategies that communities have used, such as Buffalo, to close that gap on racial disparities. Can you briefly elaborate a little bit on that? That's really interesting.
Yeah, that would be, yeah, I appreciate that opportunity. So yeah, in Buffalo, there was a concerted effort. The African-American community, leaders in the African-American community, both from healthcare as well as the social justice movements, came together and secured additional resources. So what they were able to do was get $8 million in Medicaid dollars sort of diverted to help with the COVID-19 mitigating the COVID-19 epidemic in the city of Buffalo, which is half minority. And so what they were able to do was expand testing in neighborhoods that are predominantly African-American and Hispanic. They didn't just do drive-through testing, which of course doesn't work if you don't have a car. They were able to put in place walk-up testing, mobile testing, and then back this up with targeted communications. My understanding is that there were phone calls made to nearly all the households in Buffalo, in those Hispanic and African-American neighborhoods, with targeted communications, checking in on people, seeing how they were doing, and explaining what they could do to help prevent COVID, explaining the resources that were available in terms of testing. And then, sometimes there was real need to address say financial scarcity issues such as food, lack of food access, and people, then they would connect them with resources for addressing food insecurity, deliver PPE to people's homes. So it was a kind of wraparound approach addressing information, communications, testing, improvements in care, and then finally, improvements in how we address these social determinants, which can have an impact on whether or not someone gets exposed.
Okay. Well, thank you for elaborating there. And then, yeah, please take a couple minutes and tell us more about cases and deaths outside of some of the metro areas that you're displaying here for our viewers, and tell us more.
Yeah, so this is, folks on listening in know this even more than I do. That in the rate of COVID is going up in rural areas. This is the areas we're most concerned about today in the United States. And here the risk factors in some ways are quite similar because, we talked about how in the African-American community there are high rates of chronic disease. Well, the same thing is true in rural communities. And so people have more these comorbidities that are gonna make it more likely that you get serious effects from COVID-19. And then, it's interesting because we find that in rural communities, there are more close-knit social structures like extended families and church communities where people are getting together. And normally these are just so healthful, right? They promote health, but in an infectious disease situation, they can become a liability. And, the same thing is true in African-American and Latinx neighborhoods, that folks have these tight-knit social ties. So, and then if you go on and you can say, the same challenges that face minoritized communities with respect to having sort of inferior public health and health infrastructure is the same problem that people face in rural communities. I think in the last 15 years, if I remember correctly, there have been 176 rural hospitals closed. And, and the remaining hospitals, as Kelly said, have fewer per capita ICU beds. So, we were faced both with increased potential for spread of infection through these close-knit ties, as well as not being able to social distance at workplaces, and there are problems with internet bandwidth. So of course, folks can't necessarily work from home, and maybe they're working jobs like in meat processing plants where you can't work from home. And then on top of it, you get sick, and then there isn't the same kind of infrastructure that you might find in a wealthy suburban neighborhood to take care of you when you do get COVID-19.
Well, thank you, Dr. Oram. We're going to continue on just for the sake of time. Hopefully we'll have a little bit more time at the end for some questions. So we'll stay tuned. Just reminding folks that there are two ways to send us questions. You can email townhall2020@mtu.edu. You can also use the Q&A button on the bottom of Zoom if you're joining us that way. Just want to take a minute here and recognize our sponsors. Again, our COVID-19 Community Town Hall is presented by UP Health System Portage. Our sponsors include the MTech Smart Zone, Upper Peninsula Power Company, Aspirus, and the Physiological Society. We appreciate the support of our sponsors. Talking about health disparities in COVID-19, we've heard from Dr. Kelly Kam, Dr. Heather Oram, and we're going to move on to our next speaker. I have the pleasure and honor and privilege to introduce Whitney Elmer. Whitney is the country director for Mercy Corps, and she works in the Democratic Republic of Congo. And I know she's got a map and is going to orient us on where that is in case you're not familiar. So Whitney, thank you so much for being here. We look forward to hearing about your experience working in developing countries, how they're handling the pandemic, and it's great to have you with us.
Thank you, Dr. Elmer. It's a pleasure to be here with you guys this evening. So for those of you who don't know where the Democratic Republic of Congo is, it is a country that's located right in the heart of Africa. It's 2.5 times the size of Texas, so geographically quite large. I work there during the day, and at night, my family resides just to the east in Rwanda. And so the town that I live in, it's sort of like crossing the bridge between Houghton and Hancock every day. That's my commute, except for I'm crossing international borders. So we hear a lot about how the US, Europe, and other developed countries are dealing with COVID-19, but I would say the media covers much less about how some of the smaller or more developing countries may be dealing with the pandemic. So I'll speak notably to my experience in Africa, but I've also worked in 5 other countries globally with Mercy Corps, so happy to answer any questions more globally to sort of the developing world. As countries like the US and Europe have struggled, we've also seen similar struggles in the developing world, but we have seen some cases that I would say of success in terms of looking at preparedness and creativity during the pandemic to stop the spread as much as possible. Keep in mind that in some of these countries, notably in the 2 countries that I'll speak to, they've dealt with other epidemics such as Ebola, SARS, MERS, and so they have those experiences that are a little bit more recent in their institutional memory than some countries in the US or in Europe. So when resources are limited, containment and prevention have been very effective strategies in a country such as Rwanda. In March, as soon as the pandemic started to spread, they closed their borders immediately. All international borders were closed. There was a very strict confinement period. They put in place mandatory mask wearing very early on. And then as things gradually started to reopen in the summer months, June, July, that reopening was also coupled with very strict measures around mitigation that were enforced. So that included quarantine upon arrival for travelers. So for example, when I travel back to Rwanda in January after the holidays, I'll have to spend 24 hours in quarantine in a government mandated hotel until I have a negative test result. If I test positive, I'll have to go to a government treatment facility. Rwanda is a very small country. And so again, these very strict measures have been more easily enforced and easily put into place. And at the time in March when it shut down, they only had a handful of cases. So they really went strong very early on. And so far, they've been able to keep the number of cases in the country under 10,000. They also put in place rapid testing that was available in all major cities, and that was done pretty early on. So there was quite a big investment in the testing capacity. And they also did measures similar to the ones, it sounds like, in Buffalo, where there was kind of that neighborhood type of approach, particularly in areas where they were seeing these very high caseloads. And so in Rwanda, they had mandatory testing for individuals living in those neighborhoods where there was a spike in cases. in other countries, in the developing world, they're struggling. So in the Democratic Republic of Congo, it's a very large country. There's a population of over 79 million people. I said geographically, it's quite large, so 2.5 times the size of Texas geographically. And it's been difficult to, really contain the spread there, mainly due to just weak infrastructure and very poor public services. Testing is not widely available. The enforcement of those prevention measures has not been something that's been prioritized. And they already had a very weak public health system, or a weak health and medical system, even before the pandemic. So for instance, just to put this in perspective, that country of over 79 million people, there were only about 100 respirators available in the entire country in public health facilities. So, that's very weak in terms of what would be needed and prepared for this type of an epidemic. They've struggled to ramp up the testing, and I would say most of those efforts have been really put in place in more private clinics. And so this is a country where, again, the majority of the population make less than $1 a day. And so people just can't afford to go to private clinics for that type of care. And that's where the more effective or advanced care would be available. That said, I would say that a country like DRC, again, was a little bit more prepared on the public health front, because they had recently dealt with another epidemic, Ebola. So in the eastern part of the country where I work, in 2018 until mid-2020, they dealt with the country's most deadly Ebola epidemic. And Ebola is much more deadly than COVID. So the mortality rate with Ebola is about 65%, which means, again, once someone contracts it, about 65% have a chance of dying. And so, again, there was a lot of effort put into the prevention aspects for that public health crisis. So strict hygiene measures that are very similar, except for mask wearing. So very similar to the hygiene measures put in place for COVID: hand washing, no touching, social distancing. And so there were businesses and, in a lot of public spaces, at least in the eastern part of the country, people were used to that. Every day before I go to my office, we have a mandatory temperature check. And so that was already in place for Ebola. And when COVID started, we already had all of those measures in place, and we'd been, doing those types of behaviors for over 2 years. So it wasn't too much of a shift to start wearing masks and continue doing the rest of the prevention measures that we had already been doing previous to the start of COVID. I think the big balance, of course, is, as I mentioned, finding or putting efforts both into prevention as well as actually enforcing the measures. So, if measures aren't respected in businesses, in public places, then those risks are still there. I do think there's definitely some lessons that can be pulled from countries like the DRC as well as Rwanda. Coupling the public health side with the medical side is crucial. Behavior change doesn't happen overnight. We may know what needs to be done to prevent the spread of disease, but it's hard to actually do that and practice that in our daily lives. And so really, making sure that people understand, but then also, there's messaging and again, making sure the prevention side is in place, but then coupling that with making testing available, treatment, and improving medical care. They have to go hand in hand together. Without it, just the medical side or just a vaccine or treatment, it's not going to be enough to stop it quickly enough. It's going to take a lot longer if we only focus on that medical side and forget about the prevention piece. So the two really need to go hand in hand together. Some of you may have heard that notably in Africa, they've said that COVID-19 hasn't impacted Africa as much as, say, Europe or the Americas. That seems to be true so far, especially when we look at the fatality rates. It is lower overall in Africa. It's not, I would say Africa generally has not seen as high of an exponential spread of COVID-19 as what was initially predicted back in March and April. We do know, as I mentioned, in many of the countries, the testing capacity is inefficient, but they're not seeing as many of the severe cases or as many deaths. Some of the reasons for that, I think, are there's a number of different reasons. And, the WHO they believe that it's a mix of both socio-ecological factors that include, lower population density in areas. Much of these countries, notably like a country like the Democratic Republic of Congo, there's a lot more people in rural areas than in urban areas. The hot and humid climate is also believed to be a factor of why it's not impacted Africa as much. Generally, the population tends to be much younger in these countries. So again, what we know about COVID-19, there are a lot of asymptomatic cases. Young people get sick and in many cases they do recover quite quickly, or they may not know that they were even sick. So that may be a factor. And then, another factor may just be that Africa was sort of hit with the virus later than some of these other countries. And, by that point, lockdowns were already put in place. There were already certain travel restrictions. Generally, it's harder to travel, in some of these African countries. There's just access challenges, physical access, less roads. And there were restrictions put in place pretty quickly by airlines. So those are some of the potential reasons. But again, I think time will show if we do see spikes later on towards the end of this year, or even into the spring of next year.
Thank you, Whitney. I want to circle back to when Dr. Cam talked about vaccines, and if you could speak to that. We're hearing, some promising news talking about getting the vaccine approved here, mass production of the vaccine. Can you comment at all on the forecast for what it looks like for developing countries? I know it's a little early still, but how does it even, do you begin to plan and prepare for the potential of a vaccine down the road?
That's a great question. I think there's a lot of uncertainty about when the vaccines may be available in developing countries, or in some of these smaller countries that may not have the resources available to purchase large-scale vaccines. And so I think, again, it appears that when the vaccines are first available, those will most likely go to the countries that can afford those and afford to roll them out quite widely. And then, these other countries may be sort of prioritized later. It's still a little bit unclear. I think, the good thing in DRC is that, again, with Ebola, people are a little bit more used to vaccines that are in the early phases. So there was a use of the Ebola vaccine, which, again, was in kind of it had been approved. It's in its final stages of approval, but often that approval can take up to 10, 15 years for kind of that mass production of certain vaccines. So, people are a little bit more aware of using more experimental or kind of trial vaccines, but again, it's very unclear when or if that will be available, even in 2021 in a country like DRC. I think Rwanda, it has a little bit more resources, and since they've been able to keep the caseload down quite a lot, I imagine that they'll be able to have access to the vaccine, at least for their healthcare personnel, probably a little bit sooner.
One more question for Whitney here. Very good question that came in our Q&A button on the Zoom here, talking about the role of the military in these developing countries. How do they factor in with a health crisis or a COVID-19? Can you comment on that?
Yeah, so certainly they factor in quite a bit. When I had talked about the enforcement piece, just to give you an example, in Rwanda, if you don't wear your mask, the penalty is to go to a public stadium and just sit in the stadium for the day. And that's controlled by both the local police and the military. You know, again, that's a very extreme measure. In other countries, it may be more about just taxing or fining someone. So again, I think it depends on how the government, you know, is used to operating. And in Rwanda, that works. It is much more militarized. In DRC, you know, that I would say very little is done kind of on that enforcement side. So it really depends.
We're going to continue to welcome some more questions in here for the entire panel. This one I'm going to direct to Dr. Heather Oram from University of Buffalo, who's with us today. This is a question from a community member, and I'll just read this from the chat button here, and hopefully I can piece this together. So talking about, could the poor quality of healthcare at the rural and community hospitals be related to the shortage of healthcare professionals in rural areas? They're also asking, what is the current state of nursing shortages in Michigan? I don't know if you know that, but just kind of talking about the rural health challenges that we face with staffing and some of the shortages and how that might impact. Can you comment on that, Dr. Oram?
Well, 100%. I think everybody in the room is going to say, of course, that's a big problem. And we know that, you know, nurses are flying all over the country trying to stop the leak in shortages of nursing. And, you know, what the thing is that these travel nurses are very, very expensive. So because we have, you know, there was a lack of infrastructure to start with, now hospitals are then going, you know, basically going into debt to hire travel nurses, which are very expensive, and this creates a cascade of problems, right? And, you know, maybe the fact is that you don't have enough nursing staff. You just can't get it. Of course, you know, everybody heard the news about this idea. I think it was in North Dakota where we would start to allow nurses who have COVID to treat patients. I actually don't think that eventually came to fruition, but you know, that's how severe the shortage is. And the second part of the question, I don't actually know, maybe Kelly knows the answer to that. I don't know what the status of things are in Michigan. I apologize.
Another question came in. I'm going to open this up to the entire panel here. This community member is asking if we could go back to March, at least the beginning of the pandemic, so to speak, here in the United States, and maybe even a little bit earlier. What is the one thing that all collectively you wish you would have known, if that would help you now? So maybe we can start with Dr. Cam.
I think from a public health perspective, it's been really critical to see how important leadership is at all levels, to have a unified response that is modeled at all levels, at institutional levels, at state and federal levels, to have that really be there and the driving force of the science behind it, and really being able to explain to people, you know, that the information is changing, and it's not because we were lying before, but that we know more now, and really kind of keeping that information going, and that leadership has been a critical part.
Thanks, Dr. Cam. We'll go to Dr. Oram next.
Yeah, just to build off of what you said, Dr. Cam, you know, having a federal response would have probably made a big difference. But I'll add to that and say, I wish we had better known how to message about prevention, mask wearing, and social distancing to people who have a more individualistic worldview. So we've done some research showing that folks who are more individualistic sort of have this sense of individual responsibility being a primary driver of their worldview, that they're just less likely to engage in these preventive behaviors. And I wish we had known how to reach, in particular, these folks with a message that appealed to them about mask wearing. Yeah.
And we'll go to Whitney next.
I fully agree. The leadership piece is key, and consistency across leadership, you know, in a country is really important when dealing with these public health crises of large scale. And then, you know, notably, I would say the guidance on, I think, mask wearing. You know, that was, even if the research was still a little bit unclear, I think even in March, if we had just said, do it as a preventative measure, that could have helped a lot.
Thank you. We had a comment come in from a community member reminding us, this is a great reminder that it's not just the shortage of nurses, for example, it's other laboratory professionals, those involved in the public health department. So it's really across the board. So thank you for that comment from that community member. With the sake of time, because this is our last town hall, I want to give each of you just maybe 30 seconds or less, if you could just comment on a key message that you'd want our audience to take away from tonight. And after that, I'll just wrap up with a couple of closing remarks since it's our final town hall. So we'll go in maybe reverse order. Whitney, if we could start with you. Any key takeaway messages or recommendations that you have for our listeners and our viewers tonight?
I would just say, I think with this pandemic, what's become clear is that everyone is struggling all across the world. It's not just a US issue. It's not just a Europe issue. It's something that's impacting everyone. And I think, you know, again, from what I've been able to observe, being in a few different countries, it's very similar. It's challenging. You know, we all are having a hard time not seeing our friends and family. We're having a hard time doing the things we know we need to do to protect ourselves, but most importantly, also protect others. And yet, you know, it's temporary. We will get through this. And so I think people just need to keep that in mind. There will be an end. We don't know when. You know, we don't know what that's going to look like, but it will come. This is not the first epidemic that's happened in the world. It's not going to be the last. And so we all need to do what we can to continue to protect ourselves and just to prevent the spread. And it will end. And the sooner it can end, the more quickly we can get back to, you know, somewhat of normalcy that we were used to before this.
Great. Thank you, Whitney. We'll go to Dr. Heather Oram next.
So I think we're going to learn such valuable lessons from this. We are learning the importance of investing in public health infrastructure. We are learning the importance of taking a close look at systemic racism and understanding how it is contributing to the overall illness and ill health of the nation. And so we can, and we'll go as far as to say, you know, we're understanding that climate change has a role to play in these kinds of epidemics. So we're gonna, hopefully we will learn from this really tragic and difficult experience. And in the future, we are gonna prioritize justice, public health, and climate change mitigation.
And Dr. Cam.
I would say that to remember that everybody is in our society, whether they're global citizens or citizens that we live next door to, and that everything that we do impacts them on our health and their health. And we're all bound together, no matter if we're in Central Africa or over in Buffalo or here in the UP, all of our health is connected.
Well, I want to give a special thank you to Dr. Heather Oram and Ms. Whitney Elmer for joining us tonight, and also to Dr. Kelly Cam. We really appreciate your insight, your perspective, answering our questions for our listeners and our viewers. For those of you on the Zoom webinar and social media, I have a slide up here with there's about 35 individuals. These are experts that have been on the town hall the last 12 weeks, providing again the information, the credible information, and these are people that we trust. So thank you to all of the clinicians, public health officials, community experts. We've had current students, former students, alumni, and many people on here. We really appreciate it. I want to thank our sponsors one last time: UP Health System Portage, the MTech Smart Zone, the Upper Peninsula Power Company, Aspirus, and the Physiological Society. We truly couldn't have done it without your support. Also, give a special shout out to the Health Research Institute and the Center for Educational Outreach. There's a number of people working behind the scenes that have helped us: Lydia Lytle, Cody Kangas, Cassie Munoz, Grace Schmitz, and Jody Lehman. Thank you for your support, helping us make this possible. Many have been asking about the next town hall. This is the last one of 2020. We'll be back in January of 2021. We'd encourage you to go to our website. We'll have the dates and the details up. Our website is mtu.edu/health-research. Finally, I want to thank all of the listeners on 97.7 The Wolf. Thank you for The Wolf for partnering with us. Those folks that are using social media to stay informed about COVID-19 and all the folks that have joined us on Zoom. I want to wish everybody a safe and healthy holiday season, and we will see you next year. Thank you again, and have a good rest of your evening.